to this webinar on Introduction to Oncology for Clinical Researchers. So I will share my camera so you can see how I look like. So my name is Nell Stockard, and I'm one of the trainers for ECCRT. So I'm here as a moderator, so I will manage the questions and chat for you during the whole webinar. And I will also ensure that it's recorded and help you if you have some problems, and will be there for launching also quizzes. I will collect all your questions and you will stay muted during the whole session, but all the questions will be answered at the end of the webinars with the trainer. And the trainer that I'm really happy to introduce is Lisbeth Lemmens, who is an expert in oncology. So Lisbeth, I leave you the floor now, and I will stop my camera.
Hi, everybody. I hope you can hear me.
Yes, we can, Lisbeth.
That is perfect. First of all, I need to apologize because I'm having a bit of a cold, so my voice is not sounding as clear as normal, but I do hope that you can understand me. We are now talking about the introduction to oncology for clinical researchers, and the title of this webinar actually was The Changing Landscape in Oncology, and it is indeed changing. It is not the way it was in the 70s, and that is what I'm going to explain to you during this webinar. Now, if we want to talk about cancer, of course, we need to know what is a normal cell growth. We need to see what are the physiological mechanisms and what is happening inside a cell to make it grow, to make it divide. And we can compare this to a car. If you have a key, because you want to drive your car, you need a key. You put the key inside the lock, you turn the key, and then you will start a process towards the engine. There are also some pedals where you can give gas, or you can even have a pedal where you can push the brake and the car will stop. If we go and take a look at our normal cell, and I'm not talking about a cancer cell, but a normal cell, you can see in the middle of this slide that we need a ligand, that we need a protein, our key, and this ligand will bind to a receptor. This is our lock. Once this ligand has bind to the receptor, and you switch it on, like you do with the key in your car, this is when you start a whole crosstalk between the pathways, one step to another. So we go from F to G to H to Y, and finally, this will reach our engine, the nucleus of our cell, the motor, and this is where the car will start, or where the cell will get a message that they can divide. Of course, in cases of cancer, we don't want these cells to divide. We want them to stop dividing. And this is where we are going to put in some targeted therapies. This is where we're going to use some therapies that will block, as you can see on the left side of the slide, that will block our road so that the messages can no longer go to the nucleus, and there will be no message sent that the cell can divide, and the cancer cell, in case of cancer, will stop dividing. Cancer is a genetic disease, and you have heard more and more, I guess, about mutations, things that have changed. A mutation is a change, and in case of cancer, there are changes in the DNA. And this is our very important materials that will tell us about the type of the cell and what the actual activity of our cell is. Now, normally, these changes are being repaired or suppressed, but in case of cancer, there is no more suppression. And let's just see, when we talk about our car, where I said about the brakes, that we have a gas and a brake pedal, these brakes are lost. So in cancer, there is no more suppression. So if you add an oncogene, such as tobacco or unhealthy food or sunlight, over activated sunlight, this will cause some damage. And then you will see that there is no more brake, there is no more suppression, there is no mechanism that will delete or that will destroy these abnormal cells. And then, of course, if you don't have a brake, this will collapse and you will get you will hit the wall, and in case of cancer, this can make you die of it if you don't take care of this. Now, just take a look at this slide, and you can see that this is a case of non-small cell lung cancer. And you can see on the left side in the 1999 that there was only a histological based subtyping. You had a squamous cell type or you had an adenocarcinoma. Nowadays, in 2010, and we even got more information nowadays, you can see that there is even more known about these subtypes, about these mutations that will cause squamous cell cancer. Now, this is really important because in the past, we just told patients like, look, I'm sorry, but you've got lung cancer. And they will start treat the patients with either surgery or chemotherapy. Nowadays, they can take a look at the subtypes of these drivers, of the oncogenic drivers. And this is where they treat our patients with very, very specific treatment, very personalized treatment, personalized medicine. So it's not just one size fits all. Nowadays, they really need to take care, they need very closely what are the specific characteristics of this cancer type. Now, what are the acquired capabilities of cancer cells? What makes these cells so lethal? There are different capabilities. First of all, they can grow as fast as they want. Self-sufficiency of growth factors. They can either activate them, they can create growth factors, and you can hear it in the word growth, so they make cell growth. Even if our body has, even if our system has anti-growth factors, normally, these cancer cells are insensitive to these anti-growth factors. They just deny all the messages, they just deny all these anti-growth factors. They can even grow, replicate, they can replicate themselves limitless, continue to replicate. They can evade senescence and apoptosis, and these are two difficult words. And senescence is actually the mechanism that will stop the cell from dividing. The cell will still be active, but can no longer divide. In case of cancer, this mechanism is lost, so the cell will continue to divide. Apoptosis is normal cell death. So once a cell is old, it will die and it will be destroyed. In case of cancer, there is no mechanism, or they will overrule this normal cell death. A cancer cell is a very smart cell because it can even evade the immune system. Normally, like I'm having a bad cold, normally my immune system is already active and is working on destroying this virus. In case of cancer, these cancer cells are very smart and they just evade the immune system. The immune system will not recognize the cancer cell and they will not destroy, and this cancer cell can continue dividing, continue growing, and create a tumor. Secondly, we've got last but not least, we've got sustained angiogenesis. And angiogenesis is a mechanism of blood vessel development. So these cancer cells can create their own blood vessels. And if patients are seeing their physician, it is often because they have a sign of blood loss. When they cough, there is some blood in their sputa. If they go to the toilet in their stool, they can see some blood, or they urinate some blood. This is because these cancer cells are creating abnormal blood vessels that are not tight and that are leaking. So they are losing some blood. And this is a symptom of this abnormal process. And finally, a cell can invade tissue and cause metastasis. So it's not that it's pushing away, like with a cyst, that it's pushing away surrounding tissue. No, it's really invading. So it is growing through the bowel wall, for instance. Or they can even travel throughout the body and cause or create different sites, different tumor sites. A colon cell, colorectal cancer cell, can finally end up in the liver or in the lungs. And depending on the cancer type, you will find metastasis in different places of the body. And this is the hallmarks of cancer nowadays. On the left side, you can see in 2000, This is what they knew from cancer cells right that time, that they were resistant to cell death, if you take a look on the left side, or that they indeed could induce angiogenesis, creating the blood vessels, or that they could stay immortal. They could invade and metastasize. Um, these evading growth suppressors, they keep continue activate growth factors. And on the right side, that this is 2011, and we already get more information nowadays, you can see what they know about cancer cells. And if you know a lot about these cells, maybe pharma companies can develop new drugs, new ways, new mechanisms to evade or to induce or to activate or to make sure that these cells are killed, or at least that they stop from growing. Now, as I said previously, it is really important that we know all about the subtype of our cancer cell. So first of all, we need to classify our cancer. Is it a solid tumor, fast, or is it hematological tumor? Is it more a liquid tumor like leukemia? An example of an hematological tumor. A solid tumor can be gastric tumor, can be lung cancer, liver cancer. These are solid tumors. Huh? And we need to differentiate them. We need to see what is the histopathological diagnosis, the grading. And this means how can we see how bad the situation is. If we talk about grading the tumor, we are going to see how well this cell, this cancer cell, is differentiating, is different from a normal cell. Let's give you an example. If the grade of a tumor cell is grade 4, this means that we hardly cannot recognize the stage of this or the origin of the cell, and this is a very bad situation. We can also take a look at the tumor, localization of the tumor. We can see if there are some nodules surrounding the tumor or even from a further distance, or we can even check metastasis, if there are metastases or if there are no metastases. This is what they call TNM classification. So we're going to take a look at the tumor, the nodules, and the metastases. And we can even put them in stages. If we talk about the stage 1 tumor classification, this means that the situation is not too bad. If we talk about stage 4, this means that the situation is really bad and the prognosis isn't that good. We don't only need histopathological diagnosis, we also need a molecular diagnosis. We want to see what are the types of mutations, what is missing, what has changed, what has been deleted. We need to know all this information before we can start the treatment of our patients. We also want to see what kind of biomarkers are present. Are some lab values abnormal? Is something missing? Is something too high, too low? This is really important. And that can also tell us something about the treatment, something about the way, or predict how patients will respond to treatments. Now you can see on the bottom of the slide that tissue is the issue and no meat, no treat. And this is really important. And if you have a pencil, please write this down and put it above your bed, because no tissue is no meat is no treat. We absolutely need to identify the subtypes. We need to identify what are the mutations before we can start the treatments. And during treatment, the biology of the tumor might change as well. So maybe if you are working within clinical research and if you're writing protocols, it might be an idea that you can ask for fresh tumor tissue to see if the biology of the tumor has changed, if we can identify more biomarkers, if we can see if there are more mutations, what is missing, what has changed, what has been deleted. Now here you can see a nice picture of how we were evolving regarding, for this, in this example, lung cancer. In the 70s, we only had surgery. Then they added some radiation. In the 80s, they said like, okay, we need to treat all our lung cancer patients with chemotherapy. Then they started to combine chemotherapies, and a lot of trials were like combining, finding the right dose for the right patient. And then in the 2000s, they started with targeted therapies. They really wanted to find or block the roads, one specific point inside or outside the cell, so that they could stop the tumor from growing. Then they said, like, okay, let's combine the two. Let's combine chemotherapy with the targeted therapy and make sure that we block and kill cells. And nowadays we are treating our patients with immunotherapy. We are trying to activate the immune system, the patient's own immune system, to recognize cancer cells and to destroy finally these really bad cells. So we're really evolved, and it's really a rapidly evolving field, and that makes it really difficult to keep on track. And that is why we need to have more information, and we need absolutely need training. Even if you are involved in clinical trials, you can see that the way protocols are written nowadays are really very different from the past, where we only were like comparing different doses. Now we are really comparing like patients within different subtypes, groups, stages. It's becoming really different and maybe a little bit complicated as well. I talk a little bit about biomarkers, and biomarkers in cancer are really important because they can tell us something about the tumor. They can even solve some of our questions, give some answers. Maybe if you take a look on the right side, like what is the chance that we will develop cancer? If you got a family where you can see that female patients are being affected by cancer, like the mother, the daughter, the grandmother, that they all have breast cancer, then you know that maybe it's important for the granddaughter that you will send her for some screening. This can be a biomarker. It can also be diagnostic. What's the type of cancer is it? I give you an example. If we have the biomarker CA19.9, this can indicate whether or not there is a presence of pancreatic cancer or not. It can also predict something. If a patient has a typical mutation, I'll give you an example again in breast cancer. If there is this BRCA gen mutation, then we know that these patients can be treated with a specific drug. If it's not present, then these patients will not benefit from a specific drug to treat the cancer. It can also tell us something about the pharmacodynamics, what's the optimal dose for the body, and it can also tell if the cancer has returned. If we see again that some blood values, specific biomarker has increased, then we know that the cancer has returned. On the left side, you can also see that is tell you about diagnosis, maybe put us in a do a risk assessment, some screening, patient stratification, and that will lead us to personalized medicine. We will bring this specific treatment for this specific patient on that specific time. And this is an example of breast cancer. They have put all the things in the same basket, like, okay, what is the histological subtype? What is the tumor grade? What are the mutations? Is this patient human? What are the hormone types? Is this an estrogen receptor positive, HER2? What is the proliferation? So there are a lot of information that can tell us something about the treatment that this patient at that moment really needs. What is needed? Is it LAM A, LAM B? So this will define very specific per patient what this patient absolutely needs. It's not just one type fits all. No, we need to specify once again what is needed for this patient. Now, what are the cancer treatment modalities? We can offer our patients surgery. We can combine this with radiotherapy. Sometimes we can see that this patient gets some chemotherapy, and chemotherapy will kill cells. This is cytotoxic, so it will kill cells, and not only the bad cells, but also some good cells. And this is really important when we talk about the side effects, the adverse events. We can treat our patients with targeted therapies. We can absolutely really specify the target, specific area inside or outside the cell where we want to put a blockage so that the tumor cannot, or that the cells cannot divide, and that the tumor will stop from growing. Maybe we need to treat our patients with some hormones, like the endocrine treatment, specifically in breast cancer. This is something that is been done. Or we can treat them with immunotherapy. And nowadays we can see that they are combining Sometimes patients, let me give the example of colorectal cancer. Sometimes we treat the patients upfront with chemotherapy to shrink the tumor. Then we send them to surgery, and afterwards we will treat our patients again for a couple of months with more chemotherapy to destroy all the tiny little remaining remains of a tumor cell. We combine targeted therapies with chemotherapy. We can combine immunotherapy with targeted therapies with chemotherapy. So depending on the tumor type, depending on the tumor itself, then you will get different combinations. Once the patient has started treatment, of course, they will develop side effects, and this is where we have to make sure that there will be supportive treatment, supportive care to treat the side effects, treat the adverse events. If the patient has stopped treatment, of course, we need to make sure that there is also some revalidation, that the patient can go back to work or that they can pick up their normal life. And finally, of course, if there is no treatment left, then we need to make sure that this patient has a very good end of life care, and that this patient can die in peace. But of course, we do hope that we can find a solution that our patients or that cancer can become a chronic disease. And that is what we are working on nowadays. Now, if we talk about drugs, every drug will have a name, a generic name and a brand name. Now, if you look at the generic name, then you can immediately see what kind of treatment this is. And if you take a look on the right side of this slide, you can see MAP and IP. Sometimes we can treat our patients with monoclonal antibodies. These are really specific drugs antibodies that will target a specific pathway. And when you can see a drug that is ending on a MAP, you will know, and you can write this down, most of the time that you will be talking about a drug that will be administered intravenously. Sometimes subcutaneously, but most of the time this patient will be treated with an infusion, will be treated with a IV line. If we treat our patients with a drug that is ending on a IP, this means that we treat our patients with a very small molecule that can enter the cell and that will have some inhibitory properties. So this cell will block something inside the cell. And this is when you see an IP at the end, erlotinib, then you will know that this patient will be treated with a pill. So if it ends on a MAP, cetuximab, this is an IV drug. If it's ending on an IP, you will see that this patient will normally be treated with a pill. Of course, we can take a look at the target itself. Bevacizumab is a drug that is working on the circulating system. If you see a drug, and let me give you an example, ipilimumab is a drug that can be used to treat skin cancer, melanoma, and this is a drug that will work on the immune system. Panitumumab, you see the two, then we are directly working on the tumor. We can also take a look at the source of the drug. Where does it come from? How is it? How is it manufactured? If it's like, for instance, cetuximab, then you will know that it's a chimeric human mouse. If it's zumab ending, then it's more humanized. And if it's mumab, then it's fully human. Why do I tell this? Why do I share this information? If you take a look at the source of the drug, then you will know if our patient needs kind of have a pre-medication to prevent our patient from having an hypersensitivity reaction or an infusion reaction. And of course, to take a look at the small molecules, most of the time tablets ending on an IP, depending on the way they work, you can see that they end in a different way. Erlotinib, you can have different drugs telling you something about lapatinib, about the way these drugs work. I can suggest to go through the link that you can see on the bottom of the slide, where you can find a lot of information about how these drugs, about the generic naming formula of these drugs. Now, if we treat our patients, of course, you will see that there might be some adverse events. And adverse adverse events can occur either really early after the start of the treatment, or um, can become present late. So it can be 1 hour after start of treatment, 2 hours, 24 hours, or even 2 weeks, or even 6 weeks after the start of treatment. But that is possible. And then we have to identify whether or not it is cancer related or it's drug related. And that is really difficult. Because if you just take a look on the left side and on the right side of the slide, you can see that both will give the same or cause the same symptoms. You can have some fatigue caused by cancer, but you can also have some fatigue caused by the drugs. It's very difficult to differentiate where it actually, what is related to the cancer, to the disease, and what is related to the drug that we are treating our patients with. In the middle, you can see that then when we talk about the co-medication, concomitant medication, and often in protocols, you can see a separate section where they talk about concomitant medication, what is prohibited, what cannot be taken, and the reason why they put it there is because some drugs can increase or decrease our dose, and that can cause more side effects or can cause that our drug is less effective. So that will be very strange that we say like, okay, this is the best drug for our patient at this moment. Why isn't he responding? It might be possible that this patient is taking in the same time a drug that will inhibit our drug, the drug that we are treating the cancer with. If we want to talk about adverse events, we all need to talk about the same. We need to report in a continuous and a correct way. And this is where we use the common terminology criteria for adverse events. This is mainly used in clinical trials. If I talk about diarrhea, I want to talk about the same. I want to think about the same when I talk to our patients. If a patient says like, I've got the diarrhea, then I need to ask, what do you mean when you talk about diarrhea? Do you go to the toilet 3 times, 4, 5, 6 times a day? Or do you only go once, but you need to really hurry to the toilet otherwise you will have a kind of an accident. So we need to talk about the same. And depending on who is talking, you can see on the right side of the slide, depending who is talking, maybe we're all talking about the same, but we use different wording. If we have a drug that will cause skin toxicity, a patient may talk about rash, I'm having a rash. But if we send our patient to a dermatologist, he might be talking about exfoliative dermatitis. We are all talking about the same, but we are using different wordings. So that is why they created the criteria to describe the adverse event so that we're all talking about the same. We also want to know about the severity of our adverse event. Is it mild? Is it moderate? Is it severe? And within this criteria, we can find a definition of what is a grade 1, a mild adverse event, and what is a really severe one causing death. This is all described in this adverse event. If we want to talk, if we want to know how bad the situation is, how bad the side effect is, the adverse events, this can be done by asking questions. When did it start? Where is it located? How long did it last? How bad is it? Are there triggers? Is there something that might improve or that can cause or increase the severity of the adverse event? And is there an association with other symptoms? Sometimes we can see that patients having a dry skin will also have a kind of itching skin. You can find more information or a really good report is described the characteristics of a good, between brackets, good adverse event. You can find this on the FDA website. And I'm just showing you these slides to tell you if we want to start treatment, if we want to start our patients with an IV drug, this is where we need to have the placement of an implantable portal access device. And you can see it here, and sometimes CRAs or people from companies ask them, what does it look like? This is what it looks like. It's a tiny little box with a membrane, with a catheter with the white line that is placed under the skin. You can see it in the middle, under the skin of the patient shoulder, right or left. and that the catheter, the white line, is going directly into the left heart chamber. And every time this patient needs treatment, the needle will be put in a tiny little box, and you can use this many, many, many times um, after each other, or for many years even. So this is just an example what it looks like. If we have treated our patients and we have kind of described all the adverse events and we started supportive treatment to take care of these adverse events, we also want to see the efficacy. Did we have a result, a good result, after we treated our patients? And we want to evaluate the response to treatment. And this is where we use the RECIST criteria, the response evaluation criteria in solid tumors. So this is not applicable in hematology. It is only applicable in solid tumor. You can see on the left side a CT scan of a liver where you can see the red arrow. This is measuring the tumor lesion. This can be a metastasis or a primary tumor in case of liver cancer. And a physician will measure the size of this lesion. And after 8 weeks, he will try to find more or less the same picture when he's sending a patient for next scan. And you can clearly see when he measures the lesion again that the size has clearly decreased. So the response to treatment for this patient is a good response. So the treatment is definitely working. Depending on the treatment that we are giving our patients, or if we talk about target immunotherapy, we will be using iRECIST. This is a very specific RECIST criteria for patients to evaluate response to treatment for patients who have been treated with immunotherapy. If you want to attend the 2-day course, you will see that we will have different workshops where we identify, where we can work on RECIST criteria and how these things are measured. And we will give you some examples, and you will calculate response to treatment your own. So finally, where are we now? Where are we now? Did we find the holy grail with all these new treatments like targeted therapies, immunotherapy, combining chemotherapy with targeted therapies? Is this the holy grail? Do we finally get a solution to treat our patients and stop cancer from growing? No, we don't have it yet. Because as you can see on the left side is an example of what a cell, the inside of a cell, you can see that there are many, many, many pathways where we can treat our patients. We can block either on the outside, on the pink line, we can block something there, blocking the lock. We can work on the outside, we can work on the inside. So there are very different ways of, and for those who speak French, bricolage, kind of switch on, turn off button, push buttons, as you can see on the picture in the middle of this screen. We're just turning on buttons and switching off. And if we switch one button, if we block one specific pathway, you can see that it will have some loops. It's kind of when you go to London or to Madrid or whatever, and you see that the metro is not working, you're not going to wait. You're going to use a bus, or you go to walk. You get car, taxi, bus, whatever. It's the same with a cell, a cancer cell. They will not just wait before they can start dividing again. No, they will find some different pathways. And by blocking one thing, you can cause different side effects, different adverse events. So we're not there yet. Are we over treating maybe our patients by combining, or by working on the immune system, or by treating them with a combination of targeted therapies and chemotherapy? So it's very difficult to say that we already have the solution to make an acute disease, a lethal disease, into a chronic disease. And depending on the stages where our illness is in, the course of the illness on the bottom of the slide, you will have different ways of treating our patients. And also, it's not just treating the patients, you can also see that there are mechanisms of resistance. even if a drug is working very well and you've got a nice response to the treatment, after a couple of weeks, months, years, you can see that the cancer cell has overruled the treatment and they have become resistant to treatment. So that's another target, another approach that we need to look upon. Finally, the end of life decision. Do we need to treat our patients, or do we need just say like, I'm sorry, we cannot help you. We will only cause side effects or adverse events. That is something that needs to be discussed as well. If you want to attend the course, and I can see that there is kind of a typo on this slide, but anyway, if you want to attend our course, this will cause a lot of challenges, of course. Huh? You need to learn about oncology because in the year 2030, there will be an increase of 50% of cancer cases and 60% of cancer deaths, of deaths will be related to cancer. So it's absolutely necessary that we start working on finding solutions um, to this lethal disease, absolutely. And if you want to learn more about this course or about this, oncology, then I would like to invite you to come and attend this course where we go in detail in all the different topics, such as histology, such as classification of cancer, such as the different treatment side effects, how to report this. So I kindly invite you to attend our 2-day course in March or May, depending on the event. Any questions? Thank you so much.
So thank you very much, Elizabeth. So indeed, if you have any questions, don't hesitate to ask them via the question system or chat system. I will look at it. So in the meantime, indeed, the webinar is recorded and will be available on our ECCRT website under the free resources beginning of next week, probably on Monday, even before. And if you want to know the exact dates, you will find it also on the website. As far as I remember, is the 28th and 29th of March. The next course is with Lisbeth. And Lisbeth is giving this course also with Dr. Pune, who is really an expert in oncology. So you will have two different people that will be able to answer all your questions as well. So, Lisbeth, I see that we have few questions. Maybe could you answer to this one? Do you think that tumor tissue is needed prior to starting treatment, or is a blood sample is enough? Because you said that we need to have materials to estimate the disease stage, but is it needed absolutely to have tumor tissue?
Yes, absolutely. Without tissue, that's what I said, tissue is the issue and no meat, no treat. This is absolutely necessary that you will ask a patient for tissue, either a fresh biopsy, where you take some fresh tissue from a metastasis, or maybe from a primary tumor. If the tumor is still in place, you can take a new biopsy to put it under the microscope, see what is the current situation, what is the subtyping, what is the molecular subtypes of a specific tumor. So for those oncologists who don't ask for tissue, I think they should be sued. Send them to jail because it's absolutely necessary to have tissue. Yeah. Or in case of hematologic tumors, bone marrow, of course, this will be the tissue.
Okay.
In case of hematological, yes.
Okay. And do you think that all patients have access to all cancer treatments?
Well, normally this is something that is a very tricky one, availability to the different treatments. I must admit that not all patients have access to the same treatments. Depending on where you live, some drugs are not reimbursed. And also, for instance, in the Netherlands, there are some types of drugs that are not available because they don't think that you can treat patients with it because they cause so many side effects or adverse events. So that's a bit of an issue, and I know that if you're very rich, maybe can buy the drugs.
Mhm.
But nowadays there is still some inequality between the different countries, between the different treatments, unfortunately. Mm.
Mm.
But of course, you can check the clinicaltrial.gov and see if you can participate in a clinical trial where you
Mhm.
do can get access to some of the drugs, of course.
Yeah.
And
So
that's a
click.
problem. In the past, we had patients like they said like, "Oh, I listen to you, professor. You know the solution, and I listen to you, and you know what is best for me." Nowadays, patients enter the outpatient clinic, and they went to the internet and they printed a lot of information, and they said like, "This is what I found on the internet, and this is what I need right now." And
Mhm.
that's completely different from the past. They just listened to what a physician told us them. Nowadays, they tell the physician what they want, and that's not easy.
No, I can imagine. I suppose that Dr. Pune can explain it a little bit more during the
Absolutely,
course.
yeah, yeah. He
Okay.
is a breast cancer specialist,
Mm.
and he knows a lot and about breast cancer, of course. But he's an oncologist in general,
Mhm.
and he's very open to answer all the questions, not only focusing on the slides, but also during workshops. We work together to see if we can get answers to all your questions.
Okay. And I have one more questions for you.
Yep.
You spoke about racist criteria to evaluate the efficacy of the response of the
Mhm.
product of the drug. Is it the only tool to measure the response?
No, no. That's what I mentioned already, is that in hematological tumors, that's a different approach. We're not going to use the RECIST criteria. Specifically in liquid tumors, they will use another one. But in solid tumors, even depending on the type of the cancer, they will use more modified
Mhm.
RECIST criteria. Let me give you an example. In liver cancer or in hepatocellular carcinoma, they will use like modified criteria or BCLC criteria. These are very different. And depending on the tumor type, you will have different classifications as well. So it's
Oh,
not
okay.
just that one size fits all here as well. No,
Mhm.
depending on the tumor type, you will have different ways of measuring the response to treatment.
Okay. And I have one more question for you, Lisbeth. This
Mhm,
is,
mhm.
do you think that immunotherapy is a good option for early stage cancer?
I think so, yes. Of course, we need to make sure that immunotherapy is not working for all tumor types. Nowadays, there's a lot of research being done on the immunotherapy because of the adverse events. You cannot make your immune system so overactive or activate this so much that you will destroy your whole body. That is
Mhm.
not possible. Start treatment with immunotherapy. That's really difficult to tell if this one is the best treatment option. I'm not
Mhm.
sure that all cancer types can be treated with immunotherapy. And as the first option, we don't know. That's the question, whether or not we should treat our patients in sequences, like start with surgery first, and like you saw in the slide when I talked about lung cancer
Mhm.
first, and then immunotherapy, or first immunotherapy is a type of targeted therapy as well, or combine it with chemotherapy. So that is depending on the tumor type. This will be the first treatment, or maybe the last one. We talk about lines. I didn't
Mhm.
discuss this during this webinar, but the treatments are defined in lines: first line treatment, second line treatment, third line treatment. And I think that we still need to do some research where immunotherapy is fitting in as a first line treatment, as the first treatment to treat a patient, or give them first surgery, radiotherapy, and then immunotherapy. Depending on the tumor type, again, you will have the start of the treatment will be different.
Okay, so thank you very much for that. So I think we can slowly close the webinar. Thank you so much, Lisbeth. I will just launch a polls for all of you. The idea is just to ask you if you find this webinar useful. So normally you should be able to answer. So you can vote. So as you can see, Lisbeth, you were quite successful because people said that they were really this webinar was useful. So thank you so much for that.
You're welcome.
Um, I just wanted to inform the people that attend this webinar that you will receive a feedback questionnaire on these webinars to ensure that it fulfill what you were waiting for, because these are the first series of free webinars we are organizing. So it's for us to ensure that we can better improve these webinars also. So I think on that we can close. And of course, you can always contact us via our website or via our email address, so info@eccrt.com. So thank you, Lisbeth.
You're welcome. Have a nice evening, and be careful, because if you're in Belgium, it's snowing and the weather is really bad. And if
Yeah,
you're elsewhere in Europe, have a nice evening. Bye bye.
thank you. Thank you. Bye.